Hello, this is Dr. Richard Fleming, and today is August 8th, 2020. I'm going to begin talking about what to do with COVID 19 patients when they become hospitalized. I am not telling you what you need to do to treat your patients. I'm only telling you what I believe is the correct treatment approach based upon the information that we have obtained from a variety of resources, including research being done on these patients, not just in the United States, but around the world, and the information that we have seen. Patients that are now going to be admitted to the hospital have already demonstrated that the ability to control the attachment of the virus and replication of the virus inside of people has not been as successful as we would like. This may either be because they didn't receive treatment pre-hospitalization, or because they are one of the two groups of individuals that are more than likely going to have an immunologic response that threatens their life. Those groups, as we have talked about, are those who are immune naive and those with the comorbidities. If you've been watching these videos, you understand I have been talking to you for some time now about the original inflammation and vascular disease theory that explains how this happens, that I first presented at American Heart Association meetings in 1994, and I've spent enough time on videos explaining all the subsequent presentations, publications that I've done up through the last couple decades, including the research that others have done on how to set the ventilators in this group of patients. If your patient is now being hospitalized for COVID-19, you have a series of very important decisions to make. And how rapidly you make those decisions are going to determine the outcomes of your patient. You need to focus on measurements to determine the severity of the problem, and you need to focus on treatments designed to improve the ability of your patients to breathe, additional treatments to try to stop the virus in its tracks, and still further treatments designed to stop the abnormal blood clotting and inflammation that these patients are now going to experience. As with all things, the sooner you begin these treatments, the greater your likelihood of success. I think if there's anything we can agree upon, delay in these patients has resulted in the deaths of hundreds of thousands of people. And if we're to believe the more recent models, for whatever benefit they are, we can now expect 300,000 dead Americans by the end of the year, almost double what we have now. If that happens, that is not because there is not the ability to treat this virus, but because you, as the practicing clinician, have decided not to step up and take care of the patient in accordance with your Hippocratic or Oath of Geneva or whatever oath you took. The governors of the states that you're in, the people in charge of your licensing boards, the FDA, Health and Human Services, Public Health Services, the CDC, and the World Health Organization are not responsible for the care of your patient. They are not going to be there with you when your patients are admitted. They are not going to be there with you when your patient dies. You and you alone have this obligation. And while it's uncomfortable to think about the ramifications of all of these people coming after you, I would hope that it is more uncomfortable for you to think about the loss of these patients. Although I realize that in this current era with fear and confusion, it is easy to forget that. It is easy to place you and a paycheck and a medical license above your patient. But the oath that you took doesn't recognize the federal government. It doesn't recognize the medical boards. It doesn't recognize the FDA or Health and Human Services or any of these other agencies. It is an oath that you took. And now is the time that you will have to decide exactly how much you are going to abide by that oath. I had a good friend, Albert Sen, who was one of the top premier cardiovascular surgeons in Europe. Albert lived during primarily World War II, and he remembered being captured by Herr Hitler's troops. They had to make decisions. Albert stood by his oath. He eventually escaped and got back to Switzerland, which is where he was from. But the similarities between what's going on in this country and Nazi Germany, too similar. But let's focus on the patient for now. When your patient comes in, you need to determine exactly how severe the problem is. There's a series of blood tests that you should be getting, and you should be getting FMTBDM. It is the only test that will allow you to quantitatively measure what's happening in the lungs of these patients to determine the severity of the infection. By having this information before you begin your next stage of treatment, and then treating your patients for 3 days, you can repeat these tests to determine the success and the need for any change in treatment within 72 hours. That can be life-saving. Everything about these tests, everything about FMTBDM, and everything about the drugs that are part of the protocol that I've put together that I'm sharing with you beginning today has already been FDA approved. You are the practicing physician. All you need to do is respond to this video posting asking for information, and I will respond to you if you are indeed a practicing physician. I will tell you what we do in this protocol, and I will work with you to make this test available where you are at for free. There's no services being rendered here on my part. In addition to these tests, to measure the severity of COVID-19 and what is happening in the body, the recommendations that I would provide to the practicing physicians to consider include the inclusion of interleukin-6 inhibitors like tocilizumab to interfere with the inflammation going on, and viral inhibition with remdesivir. These drugs should be started now, not in a week, not in 2 weeks, not in a month. If you're going to get control of this virus, you need to be doing this now. If you have already started hydroxychloroquine and zinc and azithromycin, I would recommend that you continue these and monitor the rhythm of the patient's heart. The QT interval that so many people are worried about requires a very simple electrocardiogram done every day. And all you need to do to address this is remember that they need magnesium, they need calcium, and they need potassium. And if the QT prolongs, simply treat it with IV esmolol, which will shorten it. That would be the first recommendation. Remembering that if you don't treat this virus to try to stop it from what it's doing to replicate itself and cause inflammation, that the inflammation itself can increase the QT interval, causing the same rhythm disturbance that could lead to their death. Treat the side effects with the proper medications and monitor them. The other thing that you should remember is that if they're having breathing problems because of this inflammation going on in the lungs, let's give the medications that are possible by nebulizing, airway treatments going into the lungs to improve the delivery of these drugs where they're needed most. And medications that I hear nobody talking about are medications like Atrovent being nebulized into the lungs of the patients. There are other medications that can be used, but they will increase the heart rate, and I would recommend that you avoid those. Use the ones that will open the airways of the lungs of these patients instead of the ones that also increase the heart rate. I would also recommend that because the initial inflammatory response includes the acute innate cytotoxic response, including the T cells, that you give these patients interferon. There's a variety of them are available. The ones that we recommend are alpha 2 beta. You can nebulize some of these as well, getting them right to the lungs where they need to be, instead of having them go elsewhere throughout the body where they may not be as importantly needed. The choice is yours. If your patient is having trouble breathing, instead of putting them on a ventilator, which is easy to do, the recommendations that I would advise include prone positioning, placing them on their stomach, and using VV ECMO or VA ECMO, depending upon whether the problem is simply in their lungs or also their heart. If you need to go to a ventilator, of course, do that. But you need to realize that if you use the standard ventilatory settings of tidal volume, you increase the risk of the patient dying. If you use the lower tidal volumes that are necessary at 5 cc's per kilogram body weight for ARDS patients, which is what these patients are, the patient will tend to overbreathe the ventilator. And that's going to require additional medical treatment. That's going to make it more challenging to get the patient off the ventilator. It's easy to put somebody on a ventilator, and it is much more challenging to get someone off. These are the initial steps. In addition to using the obvious intelligent things that you should be doing, which is to addressing things like vitamin C, vitamin B6, B12, a variety of other factors that are necessary to try to keep the body healthy and in control of this immune state. We have already seen what happens when people do not address this inflammothrombotic process soon. Patients die. Patients have blood clots. Patients can develop other infections because of the inflammation, because of the body failing to respond adequately. Doctors, this is your responsibility. As uncomfortable a position as we have all been put in with everybody second guessing us, it is very clear that the FDA, HHS, Public Health Service, CDC, the World Health Organization, the governors and the state licensing boards have not stepped up to take care of the treatment of these patients. Your responsibility on admitting these patients into the hospital is to determine the severity of the problem and to initiate treatment immediately to get both the infection and the inflammation and blood clotting under control sooner than later. Failure to do so will result in the death of these patients. This is a disease that you can treat. This is a disease that we have demonstrated and others have demonstrated can be successfully treated. But it requires that we work together. And one last thing, get the patients out of bed. Quit leaving them in bed. We have known since the 1960s that getting patients, heart attack patients, out of bed as soon as possible is necessary to improve their health. You need to get them at least into a chair at the bedside. Patients that are left in bed develop decubiti, they develop blood clots, and they become weakened. And all of that serves to make them more fragile and more likely to die during this disease. My last thought is we really need to do something to get the family members back into the hospitals to see these patients. Every doctor out there who's ever dealt with someone who's critically ill knows that the ability to have a friend or family member come in and provide support and love and encouragement is critical in many of the patients turning around that we thought otherwise would not. And we have seen people suffer long periods of time without family members or support. And these patients tend to do poor for a longer period of time than those who don't have that support. We've got to start practicing medicine the way medicine has been practiced. HIV was much more alarming for those of us that were taking care of those patients. But we did not isolate those patients. We did not leave them in bed. And we did not abandon treatment because somebody else was looking over us and telling us if we did something that they didn't like, they'd pull our license or remove our hospital privileges. Go back to Semmelweis. Remember the doctor who said that if you just simply wash your hands in between the delivery of one baby or another, that the infant mortality would be dropped. Semmelweis lost his medical license. They removed him from his colleges that he was a part of. And shortly after his death, when hand washing started to occur, the death rate of infants in hospitals dropped by 50%. Just because there are people that you are worried about attacking you as a physician does not mean you can abandon the patient. You are the patient's hope. You and the nurses and the respiratory therapists and the nuclear technologists and the physical therapists working in the hospital, you need to reclaim your role in the treatment of these patients. Measure what's going on. Initiate the treatment on the virus that we have available and to stop the blood clotting and inflammation that's going on. Do not let those who are not taking care of patients tell you how to practice medicine or nursing or nuclear technology or physical therapy or nutrition. It's time for us to take back control of medicine and take care of our patients.